Okay, Assalamu alaikum everyone. My name is Nawaal and I'm a second year medical student. I hope that everyone's Ramadan went well and that may all our prayers be accepted. I mean, today's PAL session will be about parturition and lactation, and this is a short and easy topic, inshallah. So this is the content of the slides. Let's start with parturition. This is the stress-induced model of labor. And then we have the role of estrogen and oxytocin in parturition. We have mammogenesis and lactogenesis, and then something called lactational amenorrhea. And then we're going to go for menopause, contraceptive methods, and then we're going to discuss twins and APGAR. Okay, so for parturition, this term refers to the entire process of labor and delivery, from the start of uterine contractions to the expulsion of the baby and the placenta. So 38 to 40 weeks later, pregnancy is almost done. The baby starts to push. So why is the baby pushing? Is it magical? How does it know it's time? We shall come to that in a bit. And then the opening of the cervix becomes larger and the mucus plug is released. The baby's head pushes against the cervix. The myometrium is stretched, and this sets off a positive feedback loop. The contractions here may last several hours. Delivery is usually takes like an hour, and delivery of the placenta is within 10 minutes, and then the bleeding stops. Now we're going to talk about this hormone, corticotropin releasing hormone. I would recommend that you refer to the previous lecture once for the functions of the hormones in pregnancy, because those are very important and they will make everything fall into place if you are confused. But for now, we will talk about the main characters of parturition. The placenta makes CRH, which goes to the maternal pituitary gland to induce the release of cortisol. Now, cortisol, as we all know, is the stress hormone, okay? It involves, first of all, proteolysis that provides amino acids for the baby, and it goes to the fetal circulation once the lungs are formed to initiate labor. Excuse me. Okay. So when the lungs are fully formed, they need air. Okay, they just can't have fluid inside. And then CRH, which was previously unable to reach the fetus, it can now cross the placenta and stimulate the adrenal glands of the fetus to make cortisol. Okay. Now you have stress hormone beside the fetus, and the fetus is going to be like stressed. Okay. And the fetus is going to start pushing against the cervix to get out because the lungs need air. And now there's more cortisol, and then more cortisol means that more CRH is crossing into the placenta. So this sets off another positive feedback loop. Now we're going to talk about the function of CRH. Okay, as we already discussed, induces fetal adrenal glands to make cortisol and also induces myometrial contractions. This is because of sensitization of the uterus to prostaglandins and oxytocin. Before labor, the fetus is protected from excess cortisol by this enzyme, which converts the cortisol to cortisone, which is harmless to the baby. Now we're going to talk about estrogen and oxytocin. As the cervix is stretched, a neuroendocrine reflex causes release of oxytocin. Oxytocin is released from the posterior pituitary, and it induces further uterine contractions. So these further uterine contractions cause the release of more oxytocin, and so on and so forth. This is a very important example of a positive feedback loop. But then we need receptors for that oxytocin to bind to, right? This is where estrogen comes into play. Estrogen increases myometrial oxytocin receptors. And then for the clinical part, if you want to induce parturition, you're just going to give the lady oxytocin. This is a diagram from AJR's lecture, and this is very important. I mean, it helps you understand. So baby's pushing against the cervix over here. I hope you can see this little pen thing. Stretch of cervix induces the neuroendocrine reflex. This is going to go all the way to the hypothalamic, SON, and PVN. Don't worry about the full forms, okay? This is going to stimulate the posterior pituitary to release oxytocin, release oxytocin. And this is going to induce uterine contractions and then stretch of the cervix, and then this repeats in the loop. And placenta, estrogen. Okay, Estrogen, again, is going to increase the upregulation or the synthesis as well of oxytocin receptors. And when you have that, you have more oxytocin binding, and then you have contractions. Okay. Then we're going to talk about prostaglandins and estrogen again. Estrogen also increases prostaglandin synthesis, specifically these two, PGF2 alpha and PGE2, which is prostaglandin 2. They come through the circulation and bind to their receptors. Prostaglandins stimulate uterine secretions. Wait, secretions? Okay, this is not secretions, by the way. This is contractions. Sorry about the mistake. Stretch of uterine smooth muscle stimulates muscle contraction and prostaglandin synthesis. This is basically the summary. Now, up till here, this is very easy, okay? You have stress hormone and then stress-induced labor, and then you have CRH, estrogen, and oxytocin. Oxytocin causes a positive feedback loop, and that causes contractions, okay? Easy peasy. Question time. Where is oxytocin released from? We just talked about this. Can anybody answer me, please? Okay. Okay, the answer is posterior pituitary. Moving on to mammogenesis. Now, one mammary gland is made up of 20 lobes, which includes the lactiferous duct, and they all have this duct that goes to the nipple, okay? The lobes have lobules with secretory alveoli. What are the secretions? Milk and a terminal duct, okay? Oxytocin, the hormone that we mentioned before, makes myoepithelial cells contract, which expels milk. Now, myo, we all know from myocardium, you know, muscle cells, basically. They surround these milk-producing cells in the mammary gland, okay? And when these myoepithelial cells contract, they're going to expel milk. All these cells are supported by connective tissues and adipose tissues, okay? When an infant suckles on the nipple, there is an erection of the nipple, okay? This is by sympathetic stimulation of the smooth muscle. Increase in estrogen and progesterone during puberty and pregnancy allows mammogenesis. And most of mammogenesis is during pregnancy. Okay, milk. Oh, very self-explanatory, okay. Estrogen makes the breast grow and stimulates the anterior pituitary to make prolactin. Again, estrogen is doing everything, which continues breast growth during pregnancy. No milk is made due to progesterone, even though the genes are present. Okay. Progesterone is made by the placenta. So as long as you have the placenta, you're not going to have any milk production. No progesterone equals prolactin stimulates alveoli to undergo galactopoiesis. So once you're done with pregnancy, placenta is out of the body, prolactin will start stimulating the alveoli to undergo lactogenesis and galactopoiesis. Okay, now we're going to talk about lactogenesis. After parturition, colostrum is released. Okay, so colostrum is not milk. It's like this very thick yellow liquid, and it contains antimicrobial and anti-inflammatory peptides, very good for the baby. This was a question in the 16th batch exam, and it's very important, okay? So don't forget that. Suckling, excuse me, causes prolactin release, which is a neuroendocrine reflex where dopamine secretion is reduced. Oxytocin is also released, so myoepithelial cells contract. This is called the let-down reflex. May also be caused by psychogenic stimuli. Okay. Basically, what this means is that during suckling, the nipple is stimulated, okay? The sensory nerves carry this information to the hypothalamus, which inhibits dopamine. Now, dopamine normally inhibits prolactin, but now that dopamine is inhibited, prolactin is free to do whatever it wants, okay? And that is milk synthesis. So more prolactin is released from the anterior pituitary, and milk synthesis takes place in the alveolar epithelial cells, okay? The hypothalamus, again, signals the posterior pituitary to release oxytocin. We're talking about this part, which causes the myoepithelial cells around the alveoli to contract, and this results in milk ejection, also called the let-down reflex, okay? And psychogenic basically means that if a woman is watching TV and she hears a baby cry on TV, she's going to have the let-down reflex because it is psychogenic. There is a very important aspect to all of this, that is increase in prolactin is going to cause a decrease in gonadotropin releasing hormone. Can you please pause the recording for a sec? All right, sorry for that. Security was over there. Okay. Yeah, so back to this. Increase in prolactin will cause a decrease in gonadotropin releasing hormone, which will cause a decrease in LH and FSH. This is going to cause lactational amenorrhea. Okay, because lactation requires prolactin, normal insulin, cortisol, and thyroid hormones. Just remember that. This was in the slides. What is lactational amenorrhea? This is basically a natural contraceptive. Okay, requires regular nursing over 24 hours. Basically, when you have an increase in PRL, there's a decrease in LH and FSH. Okay, and that is going to make the woman not ovulate, because if you remember from the diagram, the menstrual cycle diagram, you have an estrogen peak, right? And then you also have an LH peak. After that LH peak, you're going to have ovulation. If you don't have the LH peak, you're not going to have ovulation. So you're basically going to get amenorrhea, which is an absence of menstrual cycles. Now, again, this is not reliable because for you to get this amenorrhea, you have to be nursing and suckling the baby regularly during the day, throughout the day, whatever. So it's not reliable. It's not a very reliable form of contraceptive. This is for spacing pregnancies, not avoiding pregnancies. So, okay. Question time. Why is there no milk production during pregnancy? Right? Okay, yeah. Because there is no progesterone. Because there's a lot of progesterone, sorry. In pregnancy, you have the placenta. When you have the placenta, it's going to release a lot of progesterone. Progesterone is what keeps the endometrial lining over there. It's not going to like cause the breakage of the endometrial lining. So when you have a placenta, you have progesterone, and then you have no milk production. Please keep that in mind. Now we are going to be talking about menopause. If a woman is 45 to 48 years old, she's going to experience irregular cycles. And then she's going to hit menopause around 52 years. Okay. Basically, she's not gonna have any functional follicles. And that means that she's not gonna have estrogen and inhibin. Okay. This leads to a loss of negative feedback, which results in, excuse me, an increase in FSH and LH, resulting in secondary amenorrhea. Now, why does it say secondary? Primary is basically before you get your period. It's the absence of period. And then secondary is when you don't get it after, like, when you're 52. Okay, you get that. Palpitations, joint pain, and poor sleep, which leads to irritability and anxiety. Decreased libido due to decreased estrogen and testosterone. Vaginal dryness, because estrogen causes epithelialization of these cells. So when you don't have estrogen, that's not going to happen. So you're going to get dryness. This is a diagram. Now see, basically, okay, let's read. 50, 52. So between that, so around 52, you have a sharp drop in estradiol, testosterone, estrogen, all that, okay, dropped. And then you have an increase in FSH and LH right over here. That is what's going to cause all those symptoms. Dangerous estrogen. Okay. Increased estrogen exposure is due to early menarche, so when you get your period really early on. Late menopause, when you like lose your period very late. Nulliparity and not breastfeeding. So basically all these factors are going to cause a lot of estrogen in your body for a longer period of time compared to the normal average lady. This is a risk factor for getting breast and endometrial cancer. And you have to keep this in mind when you are treating patients with hormonal replacement therapy because their chances of getting breast and endometrial cancers increase significantly. Sorry. Okay. Now we're going to move on to contraceptive methods. This is from AJR slide. You have barrier methods, condoms, diaphragm, cervical sponge. Okay. It has a significant failure rate. It prevents the sperm from entering the uterus. Okay. Then you have spermicides. Basically, these are types of creams or lotions. 20 to 50% failure rates, not very reliable. Killed sperm in the vagina after insemination. Then you have sterilization, basically, vasectomy, which is when you cut off the vas deferens, and then you have tubal ligation. Okay, you cut off the fallopian tubes and you tie them. So basically, the egg and the sperm are not going to meet. Now, this has a very, very high not failure rates. This is very reliable. Okay. IUDs, these are basically like metallic devices implanted in the woman, and they prevent implantation of the blastocyst because once the endometrium lining is forming, okay, it forms, and then it touches the metal thing, it's going to break down. And when you don't have the endometrium, you're not going to have any implantation. And this is, I guess, reliable. Estrogens or progestins. Okay. Now, this is very important. AJR emphasized on this. You have the oral contraceptive pill. You have the emergency oral contraception, injectable or implantable progestins, transdermal, which is a skin patch, and you have a vaginal ring. What you need to know are this mechanism of action. Okay. Prevents ovulation by suppressing egg surge. Negative feedback. So, as I just explained, when you have the estrogen peak, you have LH peak. When you don't have the LH peak, you don't have ovulation. Okay. Thickens cervical mucus, prevents sperm from entering uterus, alters endometrium to prevent implantation of blastocyst. We'll come to that. Okay, contraception. Barrier methods, spermicides, sterilization has a high success rate. Okay. Now, tubal ligation. As I explained, fallopian tubes are cut and tied. Vasectomy, the vas deferens is cut and tied. IUD causes endometrial breakdown, no blastocyst implantation. Suppress LH surge, thicken cervical mucus, and block progesterone receptors. So basically, it doesn't block progesterone molecules. It blocks the receptors, okay? So when you have blocked receptors, progesterone will not bind. That means it cannot exert any of its effects. That will cause endometrial breakdown. And this is the mechanism for emergency contraceptive pill, which is taken within 12 to 24 hours of sexual intercourse. Hope that is clear. Then we move on to dizygotic twins. These are non-identical twins. You can have a female and a male, and they don't look very alike, but they're still twins. Dizygotic fraternal twins arise from two eggs that fertilized by two different sperm, forming two zygotes, each with a separate amniotic sac and placenta. Okay, then we have monozygotic twins. These are identical twins, okay? I think everybody has seen twins. Okay, basically, this is during the different stages of the two-cell breakdown, okay? Like different stages will give you different types of twins. So not twins, the different types of processes. So you have two-cell stage breakup. You have dichorionic diamniotic. You have two placentas and two amniotic sacs, okay? This is number one. And then you have the cell breaks up between the morula and the blastocyst stage. You have monochorionic and diamniotic. So one placenta and two amniotic sacs. This is number two. And then the cell breaks up after the blastocyst is formed. This gives you one placenta and one amniotic sac. Okay, number three. And then you have cell breaks up after formation of embryonic disc, which gives you conjoined twins. This is where you have limbs of the two people joined together, so they're conjoined. Okay. I tried to simplify it as much as possible. So you have two placentas, two amniotic sacs, and then one placenta, two amniotic sacs, one placenta, one sac, And then after embryonic disc, you have conjoined twins. Okay, then we have APGAR score. This is not going to be tested, by the way, but for your information, if it is more than 7, it's normal. If it's less than 7, you need further evaluation. Okay, I'll go through it just for the sake of it. You have score 0, you have score 1, and score 2. Okay, score 2, very healthy baby. Score 1, not very healthy baby. Score 0, emergency. Okay, like you should be scared. So score 0, paler blue, extremities blue, pink. This is appearance of the baby. Then you have the pulse. No pulse, less than 100, and then more than or equal to 100. No response to stimulation, any types of sensory. If you touch the baby, there's no stimulation. Grimaces or weak cry, and then cries and pulls away. This is normal, and that's great. Then you have no movement, arms or legs are just flexed. And then you have active movement where the baby's flailing around, and that's great. Then you have no breathing, slow irregular breathing, and then strong cry because, the baby takes its first breath and then it lets out a cry, so the air goes in. Okay. Any questions? If there are any questions, please let me know. You can also text me on my number. So if there are no questions, thank you so much for listening. I hope that this was easy and it was well understood. This is a summary. So parturition is stress-induced and positive feedback contractions with oxytocin. Okay. You have mammogenesis, which involves estrogen and progesterone and other hormones. Remember, normal levels of insulin and thyroid and all of that is necessary for all functions in pregnancy and parturition. Okay, so keep that in mind. Lactation involves prolactin but causes lactational amenorrhea. Okay, increased PRL will cause lactational amenorrhea. And then you have menopause is due to the surge in LH and FSH, and estrogen is looking up. Why? Because it causes cancer. It doesn't cause cancer, but increases the risk for cancer. So be careful when you give HRT. And then we talked about contraception and then the rates of contraception and the mechanism of action. Okay, this could be tested, but I think that AGR said that it wouldn't be tested for the 17th batch specifically, but still be sure to go over it once. And then twins, just talked about it. That's it. Thank you. Please scan the QR code for quality and support. See you later.